Our next speaker is Dr. DeMeester. Dr. DeMeester doesn't need to be introduced. His contribution to our understanding of GERD as a disease cannot be overstated. And today he will talk to us about the gastroesophageal reflux disease treatment in the gray zone.
Thank you, Karim, and it's a pleasure to address you this morning. And I think the focus of my discussion, my presentation, will be to kind of look into the future of what we can do in regards to increasing the utilization of surgery for this disease. So we're going to talk about gastroesophageal reflux disease treatment in the gray zone, and I'll have to identify to you what the gray zone is and what we can do about it. Let's see here. How do you advance this?
I think it's a big green.
Okay, there we go. I will make some references to Thorax, and I am a consultant of that, so those are my disclosures with that company. All right. Well, many people don't know this man. This is Sir James Black, who won the Nobel Prize in 1988 for developing a technique of developing drugs. His technique was to put aside sort of medicinal drugs, identify the pathophysiology of a disease, and then by chemical reactions develop a drug that would affect that pathophysiology. And he came up in that process with two drugs, the beta blocker and the H2 blocker. And as you all know, cimetidine was the first drug to exceed $1 billion in expenses in a year. And this technology, which he was rewarded for, eventually led, of course, to the discovery and the development of PPIs. And that drug was able to improve the symptoms of reflux disease to the level almost achieved by surgery, or very close, or almost similar. And it virtually eliminated. It really did. It virtually eliminated esophagitis, strictures, and giant Barrett's ulcers, and a lot of the acidic complications of gastroesophageal reflux disease. Now, since that time, since the introduction of that drug, the data has gradually emerged of what these drugs can really do. And this is an example of esomeprazole and lansoprazole, and looking at the cure rate of esophagitis. And you see that as the esophagitis gets more severe, it's more difficult for these drugs to cure the esophagitis. And that's been a consistent finding. Early esophagitis, pretty much 100%, but when you get down to severe esophagitis, grade D, you're somewhere around 75%. So it isn't quite as wonderful as it was initially said back in the 1980s. It has difficulty with advanced disease. Now, little not known is that there's another aspect of these drugs, and that is that the ability of these drugs to sustain symptom resolution, or to maintain symptom-free state, is not 100%. And you see it makes a very nice curve over this period of time where patients were monitored by their diary, that about 70%, whether you use one drug or another, will have good response, but 30% will not. That these people do not have sustained resolution of their heartburn. Two things are kind of interesting about this. One, most of you have probably never seen this graph before, because this graph is not well focused in the medical literature. There is a reason why the drug companies went to healing of esophagitis to market their drug, because it was very effective there. They didn't tell you about this aspect that, that not all the drugs, the drugs do not resolve all the symptoms, only in about 70% of patients. Vic just showed you the Lotus trial and showed you that there was a 98% or a 93% relief of symptoms in the medical group, similar to the surgical group. Vic knows this, but he probably didn't think of telling you what the drug companies did, and that was a drug-produced study. It was paid for by the drug companies. What they did is they did a 6-month run-in. Before you could enter that study, you had to go on the drug, you had to show that the drug was effective in controlling your symptoms, then you could be randomized. So these 30% of patients never got in that study. Had they been in that study, there'd be quite a difference in outcome. Now, this has led to a phenomenon that we need to understand. And if you haven't read the pro-GERD study, you should. It's a study done in Germany. All of you should read that. This is a study done where everybody was put on PPIs when they were diagnosed and followed for 2 years and see what happens to them. It was run by the Germans. It's very good. It stimulated us to look at our patients, and it points out, as that study did, that GERD is a chronic and progressive disease. And what's important is that we move from normal to no injury GERD, to esophagitis, to severe esophagitis, to Barrett's. And this can take up to 16, 20 years. Now, when you look at all the functional aspects of the esophagus during this process, the only thing that really separates normal people from people with early GERD, that is GERD that does not cause injury, is just basically acid exposure. And as you move across this and get more severe esophagitis, and you get between mild and severe, you notice there's a great change in the functional measurements. You start to lose pressure in the sphincter. The length of the sphincter is reduced, so there's a mechanically defective sphincter. You get more acid exposure to what you had here before because you lost the sphincter. And you start to have anatomical alterations. And then if you get over to Barrett's, the main thing that causes that problem is that you begin to get bile exposure and more acid exposure. The thing that happens is that there's deterioration of the LES at that point. And no matter what you've got in the form of drugs, it's very difficult to keep a person symptomatically free when he doesn't have a barrier or the barrier is giving out. Now, this has been confirmed by the AGA, the American Gastroenterological Association, and getting this kind of news, did this survey of some 1,000 patients who were on PPIs, and it became evident there again that 30% of the patients are not completely satisfied with their drugs, whereas 70% are. So it confirms that not all these people respond to these drugs the way we have been sort of told. So this made Don Castell wade into this area to evaluate it. And what he did is he did 24-hour pH monitoring on patients off PPIs and on PPIs. And what he showed you, this is the number of reflux episodes. This is the 2 hours after a gastric challenge or a meal. This is for the full 24-hour period. You see the number of reflux episodes after a meal or for the full 24-hour period are about the same. So the drug does not affect reflux episodes, but it just changes the pH as shown here. Most of you know this, of course. This is acidic pH when you're off. This is a weak or non-acid reflux up here. And when you're on the drug, of course, you have less acidic pH. But the number of reflux episodes are the same. Now, how do you identify, what's the reason for that? Well, you could have events of acid reflux, as you saw in that graph. There was a few of them when you're on PPI. So probably that's inadequate acid suppression. You could have events of weakly acid or non-acid reflux, which further medication is not going to help. Or because everybody's put on PPIs, it was an erroneous diagnosis. So if you're going to start to evaluate these patients, you got to sort out these three things. And that's what Don Castell did. He said, okay, let's take these people that are unhappy with their drugs, let's find out why they are unhappy. And he studied 200 patients. He noted that while he monitored those patients for 24 hours, 86% had symptoms during the monitoring period. He found that about 8% had acid reflux associated with those symptoms. About 35 had non-acid reflux associated with symptoms, and about 50%, 57%, they may have had symptoms, but he couldn't correlate it to the reflux episode. So he was pretty firm that there was about 35% of these patients and 8% over here that were having reflux, acid or non-acid reflux, and it was related to symptoms. So he confirmed that these people are unhappy because they're still refluxing. So here we are today. This is GERD therapy in 2011. There is about in the United States 20 million people on PPIs, prescription written, okay, not just across the counter. About 60 to 70% of those people are satisfied with their medication and are not interested in surgery. Only 2%, less than 2%, less than 1% of all these people get an operation. Surgery has done nothing for this disease, unfortunately, because we just pick up the stragglers. And we as surgeons got to do more than that if we're going to have an effect. There is 30 to 40% of patients who are unsatisfied with their medications, proven to have reflux. This is that gray zone that the title of my talk is talking about. Here we are, those people. Everybody beyond this point here, they're happy with their PPIs. They get to this point, this is that part where they start to lose happiness in their PPIs. There's 6 million people dissatisfied there. 86% of them had symptoms when they're monitored, as Don Castell pointed out. 57% of these, they couldn't relate the symptoms with the reflux events. They may probably still have GERD. It's a big area to start looking at. 8%, not enough drug. They had acid, so maybe you can increase the drugs. However, I'll tell you that double dosing doesn't really get rid of a lot of people, and people are kind of dissatisfied with double dosing. But the important point is there's 1.8 million people with documented weak acid reflux associated with symptoms, but they're unwilling to have a Nissen fundoplication. Why? Because there's side effects. Why? Because there is risk, as Vic showed you. There is a risk. And this is what we're faced with. How do we get to these people? That's the big question for the future. How do we treat these people in the gray zone? Those people got medications, they're happy. There are those who are not really in problems, and these are the stragglers who got severe disease. That's who we're operating on now. How do we get to this group in the middle? Well, I think it's time for us to get creative and to start thinking how surgery can get into that group. Now, there are 4 criteria to do that. Whatever we do must be simple. Whatever we do must be effective. Whatever we do must be free of side effects. And whatever we do must be reversible. We need something more gentle. We need something a little bit easier than the Nissen or the Toupee or the Hill. It's just too much for these people. Now, it needs to be simple. And here I've used Jim Cox's work, where Jim is the developer of the Maze procedure for atrial fibrillation. And Jim wrote a nice article about this, and it's kind of interesting. He points out that when you got a complex procedure, it's only when complexity gets down to almost zero that you get 100% adaptability. If you have a real complex procedure, surgeons don't adapt to it very well. So it's got to be simple. If you have a complex procedure, as the degree of complexity drops down, the degree of variability goes down. When you got a real complex procedure, the degree of variability is very high. We can't have great variability. The variability affects the outcome. And when you've got a complex procedure, you can't standardize it. Only when the complexity gets down low can you get 100% standardization. So whatever we do has to be simple. Second thing, it has to be effective. Now, the effectiveness may change a little bit, and I'm not sure about this, but I just want you to kind of follow this a little bit with me. This is the results of one of Lars Lindell's previous open anti-reflux randomized study between surgery and open Nissens and PPIs. It was a 12-year study. This is the pH data, and you see this is here baseline pH for the medical group, and this is the median baseline, or the median pH after therapy, 12 months of therapy, and the same for the surgical group. The yellow line represents normal level, and there's no question that surgery gets it down to normal level. Medicine doesn't get it down to normal level, but the people are happy. So I'm not sure where if we have to exactly normalize. Just keep that in mind. I think it's dangerous, but we have to be careful. But we may not. There may be a zone in here where people have to get to in reduction of acid exposure to remain asymptomatic. And maybe that's adequate. After all, if you look at all the Nissens, there's only about 80% normalization. And they do better on their symptoms. So that's a factor. However, we got to be careful because there's a lot of data that suggests if you don't get down to normal, over periods of years, the disease progresses. It's got to be free of side effects. This is from the Lotus study, and you can see here for dysphagia, the surgical side effects, the medical side effects. Nobody wants surgery with a side effect, particularly in the gray zone. Or here is flatulence. It just doubles over what it was before surgery with the medical group or with the medical group. Nobody wants these things. If you just talk to your patients for a while, they're very happy, but if you go in, drill down a little deeper, they'll tell you that they have flagellant problems. They like to be free of it. They call it background noise, but it's there. And if you want to move people into earlier, we've got to be free of that. And it has to be able to be reversed. I pulled this slide out from some time ago, but when we've done a lot of redos in my experience, in my years, and this is one of our studies some time ago, but you see that repair first, the number of repairs, 1, 2, 3, after a failed functional fundoplication, you can get down to an esophagectomy here in about 11% of the patients. That's a big problem. And we got to have something that's so simple that it's reversible without distorting the anatomy at the gastroesophageal junction. We needed to keep the anatomy the way it is. If you got a bad disease, okay, do an Nissen, that's okay. But for this early problem, it's got to be less. So now this is where I'm going to tell you, well, I got encouraged with thorax, and now this is what I believe. Here is a device I think meets that criteria. It's a very simple device. It's a series of magnetics that make a Roman arch when they're together, expand to 60 French when the bolus goes by, and it augments the sphincter. Doesn't wrap the sphincter, it just augments the sphincter. Placed around like this is kind of it's about the size of a ring. Here it's expanded, of course, on a laparoscopic picture. These are the outcomes of these patients in a feasibility study. You can read this in Annals of Surgery if you want to look it up. But you see here is the GERD score pre-op and post-op out to 24 months. Here you see gas bloat, pre, post, out to 24 months. Here you see dysphagia score, pre and out to 24 months. And here you see normalization. And what's interesting is that you see a gradual improvement of normalization over time. I would expect that. You augment a sphincter, let it heal, it will get better. So, to me, this is the future. We've got to think of surgery in a sort of trinomial way. Early disease, medication. Advanced disease, fundoplication, and all that we've been doing. We as surgeons need to enter the gray zone. There's over 6 million people there. And as far as we know, that hopper continues to get filled yearly. Thank you very much.